Thank you for the invitation to speak with you today about the privatization of Medicare from Medicare Advantage to direct contracting. It is a real honor to be able to present at the David Rogers Health Policy Colloquium. Now, the objectives for today are threefold. One is to describe the components of the Medicare pie, including traditional Medicare and Medicare Advantage. Two, to understand the Innovation Center mandate and the models, including accountable care organizations. And finally, to discuss a winnable strategy to end direct contracting, or DCEs as they are known. So the bottom line that I want you all to go away with today is, why should I care what is happening to Medicare? Why should I care that there is this imminent threat to traditional Medicare, which is so concerning that if it comes to pass, and if we don't stop it now, there won't be any Medicare for all left to fight for. So this is an article that was written by Pearl Health, one of the DCEs in New York City, as a response to an interview that I had with Tom Hartman a few months back, where they wrote, "There is no plot to privatize Medicare, and here is why." And I'm just going to minimize something here. Oh, there we go. Where they write, "Direct contracting isn't privatizing Medicare. It employs public-private partnerships to improve Medicare. This type of partnership can and should coexist with goals around Medicare for all." So in the next 30 minutes or so, we're going to see how, in fact, there is a plot to privatize Medicare, and here's how. So, but first, we have a few definitions. We always have to start with definitions, sadly. Fee-for-service is probably something that you've heard about, and it occurs when doctors and other healthcare providers are paid for each service that is rendered. Now, according to most US healthcare economists, this creates this perverse incentive to overtreat, overutilize, which is responsible for the excessive healthcare costs in the United States. Now, to manage this, we have created something called managed care, first introduced in the HMO Act of 1973, signed by President Nixon. And according to managed care belief, they believe that excessive costs from doctors ordering unnecessary services can be managed through financial incentives to cut unnecessary services. And the idea behind this is that you manage the care of doctors so that they don't overtreat and overutilize. And then you also, through financial incentives, and then you also manage the care of patients by financially incentivizing them to use less care through high copays and high deductibles and high co-insurance. Now, capitation are the fixed payments in managed care per patient paid in advance. And so I made that bold because it is really important for us to remember that these fixed payments are paid in advance to the physician or the plan for the delivery of services. And the idea behind capitation is that you get this fixed payment and then you keep what you don't spend. Very, very important. Risk sharing is something else that you're going to be hearing a lot about. And this is compensation a compensation arrangement between doctors and practices and Medicare, where these doctors share the risk of financial gain or loss with Medicare. So basically, it is inserting a middleman that gets capitated fees to manage care. And then they keep what they don't spend. But the important thing is that a middleman is inserted in there to manage care. And the middleman oftentimes can be a for-profit middleman, so they have huge incentive to keep what they don't spend. Value-based care is another term that you're going to be hearing. It really has no definition. If you Google it, this is what I found: incentives that reward achieving desirable and efficient outcomes rather than rewarding the delivery of given services. Basically, it is a middleman that is managing care, that is receiving a capitated fee to manage care and keep what they don't spend. And finally, the definition of privatization is the transfer of control over public goods into public hands. Now, why do we worry about privatization? Well, this is an excellent book that I recommend everybody read, called The Privatization of Everything by Donald Cohen and Alan McKeown. And they write that privatization facilitates the upward transfer of wealth, exacerbates inequality, creates powerful interests, separates us from each other, and segregates us by race and class. And so we should worry about the privatization of everything in general and the privatization of Medicare in particular. So let's talk about that Medicare pie. Before 2003, Medicare Advantage used to be called Medicare Plus Choice, but in 2003, there was the Medicare Modernization Act that was passed by Congress, signed by President Bush. And you can see that before 2003, there were very few individuals that actually chose Medicare Plus Choice or Medicare Advantage, or they chose an insurance company to stand between them and Medicare, right? This is what is a private insurance company that would manage the care of seniors that chose Medicare Plus Choice. But you can see that a very small slice, only 5 million individuals did that. The rest of the individuals, 37 million, chose to stay in traditional Medicare. They wanted the public program. They wanted Part A and Part B and a supplemental insurance if they could afford it. So this is the public program of traditional Medicare. And that's what it was like before Medicare Advantage hit the scene. You can see the Medicare pie today, that Medicare Advantage has really ballooned out from 5 million to 27 million individuals that are choosing an insurance company that receives capitated fees, that are doing the risk sharing, and that are managing the care of their health care. About 54%, as of the latest statistics, still continue to choose fee-for-service, public Medicare, or traditional Medicare. Now, why should we worry? Well, when you look at the total budget for Medicare in 2021, it cost the government $926 billion. So you can understand why it is that the government really wants to see how they can lower costs, right? Because it's a huge amount of money. And at the same time, it's a huge amount of money for investors as well, for the private health insurance industry. And we're going to see, when we look at Medicare Advantage, how much money the private health insurance industry is actually making. So let's just talk about Medicare Advantage for a minute, because you need to understand Medicare Advantage and where it comes from before we start to talk about direct contracting entities that are going to be targeting the other piece of the pie. So when we look at Medicare Advantage, you can see that Medicare Advantage is twice as profitable as the group market. Now, the group market is the employer-sponsored health insurance, what people, when they're working and their employer pays premium and you pay the other premium. But you can see, if you compare the gross margins per member per month calculated with annual data from 2018 to 2020, you can see in the third set of bars there, Medicare Advantage, even in a pandemic year, gets so much more money than the group market. And when you think about it, individual market also has a lot of public money, as of course Medicaid managed care. So the private insurance companies are making a lot of money from the government. In fact, much more money from the government than they are from the group market, from employers and employees. Now, how does Medicare Advantage make so much money? Well, they have several tricks, and we're going to talk about the two most important tricks. And one is to maximize the revenue from Medicare, right? Remember, what we talked about is that Medicare Advantage gets these capitated fees in advance, right? Of actually giving out any healthcare. So they want to maximize the most amount of money that they can get from Medicare, and then of course minimize the revenue that is spent on patient care, right? So maximize the revenue and maximize what's coming in and minimize what goes out. So let's take these points one by one. One, to maximize revenue from Medicare, Medicare Advantage has come up with something called risk gaming or upcoding. So if you have already heard about this, please give me a minute, because it is important for us to understand this. Now, every single Medicare recipient doesn't know this, but they do have a risk score. And if the patient is sick, then their risk score goes up. And if the patient is healthy, then their risk score goes down. So let's take a look at a typical baseline risk score for a 76-year-old woman. Her risk score would be 0.45. Now, if she has type 2 diabetes, then you increase the score. If she has congestive heart failure, you increase it a little bit more. And at the end of the day, her risk score is 1.03. And CMS would pay that Medicare Advantage plan $9,000 to take care of that particular patient for the year. Now, if you upcode, then this is what happens. Now, let me make sure that everybody understands. This is the same patient, the same 76-year-old woman, okay? She's not any sicker, but she looks really sick because what Medicare Advantage plans want to do is to make her look as sick as possible so that they can get those payments in advance from Medicare, right? And so this is called upcoding, and this is what happens. Same 76-year-old woman, baseline 0.45, but now instead of obesity that gave her 0 points, now she's got morbid obesity, and you can see that her score goes up. Instead of having just type 2 diabetes, you write in that she's got diabetes with retinopathy and her score goes up. Instead of having just major depression with a risk score of 0, you say that she's got a single episode of mild major depression and her score really goes up. And if instead of calling it asthma, where you get a risk score of 0, you call it COPD, her risk score goes up. And then an ulcer, which is unspecified and has no risk score, if you say that it's a stage 3, boom, look how much more you're getting. And so at the end of the day, her risk score, same patient, she's not any sicker, right? But on paper, she looks really sick. Her risk score goes up 3.63, and CMS is paying that Medicare Advantage plan $32,000. So what happens? So at the beginning, Medicare Advantage plan gets $32,000 for this patient. They spend $9,000 on healthcare because she is going to need some healthcare throughout the year, right? So they spend the $9,000, but they keep the $23,000. And that's how they're maximizing their revenue from Medicare. Now, traditional Medicare has little incentive to code more diagnoses because there are no capitated payments there. But Medicare Advantage has huge financial incentives to code for more diagnoses and do something that we're talking about upcoding. Now, in an article that was published last year in September by Rick Gilfillan and Donald Berwick, they calculated that for every 0.1 increase in risk score, okay, those risk scores that we were just talking about, for every 0.1 increase at current enrollment levels, there are $15 billion in overpayments from CMS to Medicare Advantage. Now, MedPAC just published their report for 2020, and they think that these overpayments are $12 billion. Okay, so anywhere between $12 billion and $15 billion of overpayments from Medicare to Medicare Advantage plans. And you can see that Medicare Advantage takes home an awful lot of money in profits. So number one was maximize revenue from Medicare. And then number two is to minimize the revenue spent on beneficiaries. And how do they do that? Well, Medicare Advantage, remember, is allowed to keep its profit and overhead what it doesn't spend on medical services. Remember the capitation and the risk sharing, right? Well, it results in a very dangerous incentive to ration and restrict care for seniors with people with disabilities. And at the bottom, I included an article from the National Bureau of Economic Research on differential mortality in Medicare Advantage, where they actually described large differences in plan level mortality. So different plans have different mortalities. And if you were to move beneficiaries from plans in the bottom quartile of health effects to the top quartile plans, you would prevent 18,000 deaths per year. And it isn't just from the National Bureau of Economic Research, but many other articles have been published, and evidence shows that in fact there are significant denials of care for people under Medicare Advantage. There are cost-related problems for enrollees, narrow networks, worse health outcomes, and disenrollment of high-cost beneficiaries, particularly at the end of life. So these financial incentives do not exist in traditional Medicare. Now, back to the Medicare pie, where we just finished talking about the maroon piece of the pie, the Medicare Advantage. So now let's shift our focus to the fee-for-service traditional Medicare piece of the pie. And we're not the only ones that are shifting our focus, because this budget is $500 billion. So for a lot of people on Wall Street and a lot of investors and a lot of private health insurance companies, they're seeing $500 billion that is still being left on the table, right? So now let's shift our focus here. Before we start talking about direct contracting entities, I just want to spend 1 minute on accountable care organizations, because they are the progenitors of the direct contracting entities in traditional Medicare. So accountable care organizations were started in 2005 with a physicians group practice to create models of care to lower costs in traditional Medicare. And so these were capitated, these are capitated plans, and they live in traditional Medicare, not in Medicare Advantage, but in traditional Medicare. And they were created to lower costs for Medicare. And you can see that and this is from an article that was published by Jim Kahn and Kip Sullivan, using CMS data and MedPAC data to look at the ACO, the Accountable Care Organization, net costs to CMS from 2005 to 2017. And you know, this is sort of a complicated slide, but so we'll walk you through it. I'll walk you through it. The negative values mean net savings to Medicare, and the positive values mean net costs to Medicare. So when you look at the PGP, which is the Physicians Group Program that ran from 2005 to 2010 to try to save money, what they ended up saving is 0.3% over those 5 years to Medicare. When you look at the Pioneer Group, another ACO, they saved 0.7%. The Medicare shared savings. In their final year, they saved Medicare 0.3%. And the next generation ACOs, which is the model upon which the DCEs are being modeled, ended up costing Medicare 0.3%. So overall, ACOs, at least according to this analysis of CMS and MedPAC data, did not save Medicare any money. So you kind of have to wonder, so now to think about direct contracting entities, which government agency is responsible for direct contracting and other models such as the ACOs? Well, it didn't start with President Biden, but he's our president now, so I'm going to start with him now. He appoints the Secretary of Health and Human Services, HHS, to run the nation's healthcare systems, such as it is. And he appointed Secretary Javier Becerra to this position. And the reason I'm putting his photo up is because he's going to be prominent in the later on in our presentation. And HHS is over the Centers for Medicare and Medicaid Services, also known as CMS, and they are the ones that manage Medicare. Now, under CMS, you have this very little known agency called the Center for Medicare and Medicaid Innovation, which was created by the Affordable Care Act in 2010 with a mission to foster healthcare transformation by testing delivery models, right? So their thing is to test delivery models to pay for and deliver care that can lower costs and improve care. This is bolded and highlighted because I want you to remember this. Their models are supposed to lower costs and improve care. Now, they were given broad authority by the ACA to scale up any model to all of Medicare without congressional approval or oversight. So they can take whatever model seems to fulfill their criteria and scale it up to all of Medicare. And this is where we are right now, because direct contracting is one of the models out of the Innovation Center. It started with this individual named Adam Boehler, who is the former CEO and founder of Landmark Health, which was a small startup health group. And he was appointed by President Trump to run CMMI in 2018, where he developed direct contracting to privatize all fee-for-service Medicare. And interestingly, Landmark Health became one of the first DCEs to contract with Medicare. So I like to think of direct contracting like monopoly, where there are a lot of people in there trying to make a lot of money. So it does start with Adam Boehler, but it actually starts even before Adam Boehler, and it starts really at the very top with this company called Oxyon Venture Capital that has about 49 or 50 portfolios of startup healthcare groups. One of them was Landmark, that backed Landmark when Boehler was the CEO. Now, when Boehler became the CMMI director in 2018, he called on Oxyon Venture Capital to help him draft direct contracting, which was launched in 2019. And then it spawned all of these DCEs, such as Landmark, IORA, Oak Street, Village MD, and Clover DCE. And all of those actually were backed by Oxyon. Now, there are many, many other DCEs that are not backed by this particular venture capital, but many of them are backed by other venture capital firms and as well as private equity and private health insurance. So you have 360 and Advance, and Care Connect, and Humana, and several other private health insurance companies, Best Value, CenterWell, Andale, Vively, Perfect Health, who wouldn't want to be in that DCE, Quality Partners, another one, and Texas DCE. So this is just a smattering of the DCEs in this monopoly game, really trying to get to a lot of this money. Now, Rick O'Fallon, who was the first director of CMMI, and Donald Berwick, who was the administrator of CMS under Obama, wrote this article in Health Affairs blog in September, where they called the Medicare Gold Rush. And they looked at the Wall Street speculators that were increasing the average valuation of Medicare Advantage beneficiaries. So I find this really disturbing, but not only do patients not know about the fact that they have risk scores, right? Of course, Medicare knows, and Medicare Advantage really knows about those risk scores, but these Medicare Advantage beneficiaries also have an average valuation on Wall Street. And so historically, this valuation has been $7,000, but it has increased to $87,000 currently. And you have to think about, well, wow, is this because beneficiaries got really sick? Not really. It's the system that has gotten really sick. And so what these Wall Street speculators are banking on is the fact that we are expecting a doubling of Medicare spending from that $900 billion to $1.6 trillion in 2028 as baby boomers age. They're banking on the fact that CMS consistently overpays Medicare Advantage, and also on the fact that CMS has completely distorted the market dynamics, and they're taking advantage of that. And finally, they are banking on the fact that direct contracting model is going to privatize part of that $1.6 trillion spend. So very, very important. Now you would think, wow, okay, well, this is all under Trump, right? So Biden must have come in and stopped all of this, right? This giveaway to Wall Street. Well, sadly, that's not what happened. He appointed Liz Fowler as the director of the CMMI. She came in, tweaked around the edges, changed the name to Global and Professional Direct Contracting Model, and they set off to test the next evolution of risk sharing arrangements. And remember, risk sharing is all about, capitation and managing care and keeping what's left over, right? When you hear risk sharing, that's what you should hear. They're going to be building on lessons learned from the ACOs, right, that didn't save money, from Medicare Advantage and from private insurers. All of this is from the CMMI website. They're going to broaden participation to participants new to fee-for-service, so basically opening up the floodgates to Wall Street. And finally, quote, empower beneficiaries to choose the healthcare providers with whom they want to have a care relationship. And you have to kind of wonder what beneficiaries were doing before direct contracting entities when they were choosing their healthcare providers. So bottom line, direct contracting entities are middlemen, oftentimes for-profit middlemen, paid by CMS, that will take a page from Medicare Advantage to maximize revenue from Medicare, such as through upcoding, minimize spending on care from restricting care for seniors and people with disabilities who chose traditional Medicare. Now, DCEs really are providing new opportunities for Wall Street. On their website, it says flexible cash flows, payment recognizes the challenges of caring for complex, chronically ill patients. And this is just code for upcoding. An MLR of 60%. So let me just take a minute for those of you that might not be familiar with this term. MLR stands for medical loss ratio, and it's the parlance that insurance companies use when they lose money to providing healthcare. That's their medical loss ratio. So an insurance company that has a medical loss ratio of 90% means that they're losing 90% to provide healthcare and only keeping 10% for profit and administrative fees, okay, or administration. So that's a very bad company. And before the Accountable Care Act, private insurance companies would try to decrease their medical loss ratios as low as possible so that they could take as much as possible in profits and administration back with them. So the ACA actually put a stop to that and said that all private insurance companies, including those in Medicare Advantage, had to have a medical loss ratio of at least 85%, right? So 85% had to go to healthcare, 15% they could take home with them. Now, just to give you some context, traditional Medicare medical loss ratio, which isn't even really a medical loss ratio, is 98%. So they spend 98 cents of every dollar on healthcare and only 2% on administration. Now compare this with an MLR. Probably we can call this an implicit or an effective medical loss ratio of about 60% for direct contracting entities that are really, really savvy. Not all of them are going to get this MLR, they're not, but the ones that are really savvy and know how to game the system could get a medical loss ratio as low as 60%, but they're going to be, spending 60% on healthcare and 40% for themselves. Now, this program has already started and it's going to run through 2025. And as of today, there are 53 direct contracting entities that have been selected that have signed contracts with CMS and are operating in 38 states, DC, and Puerto Rico. Now, of the 53 DCEs, 28 are investor-owned, and many of them are publicly traded in the stock market. 25 are operated by ACOs, as well as for-profit primary care practices and managed service organizations. So the trick is, how do you get 30 million beneficiaries that have chosen traditional Medicare, right? They're the ones that said, okay, I just want traditional Medicare. I want Part A, Part B, my supplemental insurance. I do not want an insurance company between me and my doctor or me and Medicare, right? I choose traditional Medicare. So how do you get 30 million of those individuals assigned or aligned in the parlance of CMS to a direct contracting entity, right? Well, you don't tell them. Instead, what CMS is going to do is to align beneficiaries, basically, either claims or voluntary, doesn't matter. It's going to be based on their primary care provider. So this is what's happening. For those of you that have watched television from October through December, you know that seniors and people with disabilities are getting bombarded during open enrollment or open season, as I like to call it, with ads from Medicare Advantage, right? Buy this one, buy that one, this one's so much better, and so forth. Because they have to convince the beneficiaries, the seniors, to choose Medicare Advantage, right? Well, DCEs don't work that way. DCEs only have to either convince the doctors or they just buy out the doctors and become a DCE themselves. And then what happens is that all of the patients in the physician's plan go along with the physician, with the PCP, and get aligned or assigned to a direct contracting entity. And that's how it's happening. And there's going to be a potential of 30 million seniors and people with disabilities that are going to be aligned this way without their knowledge or consent. They're going to get a letter like this. This is a typical one from Clover Health Partners. Remember, that was one of the DCEs that was backed by Oxeon Venture Capital. But anyway, this is sort of a form letter. I've seen this for many other DCEs as well. And basically, this is the letter that beneficiaries are going to get, and they're going to say, your benefits have not changed. Your doctor asked Clover Health Partners to help see that you get the right care at the right time. And then, you know, they basically don't tell them anything about what a DCE is other than it's just great and it's going to give you the right care at the right time. But most important to me is the thing at the top that says required annual notice, no action needed. Now, whenever I get these letters in the mail, honestly, I don't read them and I just throw them in the trash. And I worry that that's, well, not me, but we worry that that's what's going to happen. And so this is how it's happening without their knowledge or consent. Now, for those seniors, however, that are savvy and they're saying, wait a minute, what is this DCE? And I have heard from seniors saying, very confused, what is this DCE? What is this direct contracting entity? And how is it that I'm suddenly, you know, aligned with them? So some members of PNHP and I had a meeting with Liz Fowler, the director of CMMI, back in December. And I asked her that question. I said, what if a patient wants to opt out of a DCE? They don't want it. Her answer, just find another primary care doctor. So that sort of shows you what CMMI feels about the doctor-patient relationship, about continuity of care. And they really have no idea that it's very difficult to find a primary care doctor, particularly if you're in a rural area, and particularly if all your doctors are now signed up with DCEs. So how are doctors being lured to direct contracting entities? Well, some of them are just being bought out straight up, or being created out of whole cloth, or it's usually going to be the leadership that is going to make that decision. Individual doctors today do not have that kind of power to make those kind of decisions. So how are they being lured? Well, according to the request for applications to become a DCE, doctors will be, quote, incentivized to be more attentive because they receive a share of savings on the patient's total cost of care that they generate with their increased attention. This is from There Is No Plot to Privatize Medicare from Pearl Health, says primary care physicians that perform well in the model should experience better economics. And this is from Genuine Health, another DCE, reliable income bonuses And they say that they will train the staff to improve Medicare risk assessment score, to upcode. And finally, from the CMMI, reduced administrative burden so doctors can focus on what is most important, spending time with patients. So, you know, it looks pretty promising, right? More money, more time with your patients, fewer metrics, but there's really no guarantee. What there is a guarantee is that there's a huge potential for doctors to limit or withhold care, to do well in the model, and to guide patients to DCE in-network specialists, hospitals, and diagnostic centers, even though they protest up and down that, yes, you can use any Medicare provider. The truth is that they're going to be guided to in-network specialists because that's how DCEs are going to end up restricting care and saving money. And in the end, it is going to erode the doctor-patient trust relationship. So when they write direct contracting isn't privatizing Medicare, it employs public-private partnerships to improve Medicare, and this type of partnership can and should coexist with goals around Medicare for all. I say, not. Direct contracting is privatizing Medicare. We've seen this. It transfers control of public goods to private hands. There is no evidence that direct contracting will improve Medicare, and there's no room for profit in a national improved Medicare for all. So, won't Congress try to stop it? Well, until recently, most members of Congress had never heard of direct contracting until a group of doctors from Physicians for a National Health Program went to Washington. And you can see my photo there with the purple hat on. And we went there to raise a ruckus, to raise the alarm. We went to visit Secretary Becerra, who did not allow us into the building. We had over 10,000 petitions demanding an end to DCE that he didn't accept. We met with members of Congress. We raised the alarm to tell them about what direct contracting is. It's a threat to traditional Medicare, and it's going to radically transform Medicare under their watch. And as a result of our visit in November, in January, 54 members of Congress sent a letter to Secretary Becerra demanding an end to the DCE program. And this is not a result just of our raising the alarm, because hundreds and hundreds of healthcare activists from across the country called their members of Congress to sign the letter. So it was a result of their activism. And now DCE owners and investors are fighting back to protect their profits. Now, we have an urgent, winnable strategy. How do we do this? Well, protest DCEs. There happens to be a DCE right here in New York City called Pearl Health that we've been talking about throughout this presentation. We protested the DCE in front of Humana headquarters building in Louisville, Kentucky. They have a DCE, and this was back in December, how the Grinch stole Medicare. It was really great. You can hold CMS and CMMI accountable. You can protest CMS and demand congressional hearings. We had our first protest in Atlanta, Georgia on Monday. And there just so happens to be, there are 10 regional CMS centers. There happens to be one in New York as well. You can sign the petition to Secretary Becerra. So from wherever you are right now, you can just go to www.pnhp.org. The very first thing that's going to pop up is sign this petition against DCEs. You can do this right now. We have over 11,500 signatures. Another organization collected 5,000 signatures for us. And so we have many, many signatures. We want thousands and thousands more. So this is something that you can do right now. As you're listening to me, you can go to our website and you can add your name to this petition demanding that Secretary Becerra stop direct contracting entities now. If your member of Congress did not sign the letter to Secretary Becerra demanding an end to direct contracting entities, you can still call your member of Congress. This is their phone number. This is the Capitol Switchboard phone number, 202-224-3121. You can call, give your zip code, and they will direct you to your member of Congress. And you can tell them, become a Medicare protector. I don't want direct contracting entities. I don't want the privatization of Medicare. I don't want this radical transformation of Medicare under your watch. And then finally, if you feel really motivated, you can write a letter to the editor of your newspaper or an op-ed. And if you would like some guidelines, you can go to our website for that as well. You can become creative. Some other people in California and I are sending Speaker Pelosi 1,000 Valentine's Day card. saying, Nancy, don't break my heart, hold hearings on DCEs. So if you're interested, you don't have to be from California. It's just the activists in California that organize it, but you can click on this link and you can print a PDF with the card telling Nancy Pelosi not to break your heart, and you can put it in an envelope, stamp it, and then send it to her. The address is all there for you. And I would love for you all to send her letters and telling her to hold hearings on direct contracting entities, because she has the power and the authority to do that. So I would like to close with a quote from the book, The Privatization of Everything. Privatization is not too big for the average citizen to take on. It happens at very local levels, right? You can be sitting on your couch right now or at your desk, and you can do this. And it involves corporations and politicians who are acutely susceptible to public pressure. So Medicare, don't privatize it, supersize it. And I'll be very happy to entertain any questions that you have. Thank you very much.